Hey everyone, I'm sorry about that. I just wanted to say thank you and introduce myself. I know Angelina already did, but my name is Robert Bacigalupo. I'm an oral maxillofacial surgeon, and I work at our leading edge office in Levittown. I just want to give a quick shout out to Straumann for helping sponsor tonight and sponsoring the CE. I'm going to go through a lot of things tonight as quickly as possible. So we're going to review some procedural complications tonight. We're going to review some medical emergencies as well. A lot of the procedural complications might overlap with what I went over in my last lecture. As I start most of my lectures now, I do like to say dentistry is hard. I like to say this because not many people outside of the dental profession really understand that. People kind of think our lives are easy and it's really, a joy being a dentist. And don't get me wrong, it is. But dentistry is very difficult. It's hard working on patients, doing a procedure while also making them feel comfortable and talking to them, socializing. It's a very difficult occupation. And the two gentlemen that you see pictured here, the first one many will recognize from Stony Brook is Dr. Barry Waldman. He was a mentor of mine when I went to Stony Brook. And I always remember on the first day of dental school, he came in and he said, you guys are all going to be dentists. That's great. Everyone's excited. And he said, I'll offer everyone here a job as an elevator operator for the next 30 years, and I'll pay you 100 grand a year. And all you do every day is work an elevator, go up and go down, and then go home. Who wants it? And of course, in our first year, all of us, said, no way, we want to be a dentist. And then on the last day of dental school, he moseys back in the room and he says, all right, who's taking the job? And everyone raises their hand and says, I'm taking the job without a doubt. And so it just was a funny anecdote that Dr. Waldman always used to say, it's harder than we think. So that's Dr. Barry Waldman with his anecdote. And the other gentleman here is Dr. Alan Cuisine. He is another mentor of mine from Stony Brook. He's also an oral surgeon, and he is the one for most Stony Brook graduates who had him taught us medical emergencies. And he was the one really to bring it all together for me. And he always had a very common sense approach to how to deal with anything in the office that may go wrong. And I always did appreciate that. I did feel like he always just had a firm grasp on what to do. He was always prepared. And I did learn a lot from him. So I wanted to give him a shout out as well. When it comes to dealing with emergencies in our offices, it's important to recognize that in the dental office, the dentist, all of us are usually the leaders. We're the ones that have to deal with the emergency. We're the ones that people go to for help, for guidance on what to do. And so I like to allude back to a very famous and important person in American history. This is a picture of someone called, his name is Major Dick Winters. And if we have any history buffs out there, he was kind of made very famous with the show a few years ago called Band of Brothers. And he was in the Army and he was renowned for his ability to lead. And at the time, he was only 26 years old and led a company of men through a lot of different things through World War II. And after World War II, he wrote a lot of books, and they're all really, really great books to read to learn to be a better leader. And I have two of his main quotes listed here that I think really encompass what it is to even be a dentist. We're the ones in our office every day who they look to, and we're the ones that in an ideal world as leader, we have to try to lead from the front. And that's what he always stressed. Dick Winters was known for the quote, "Follow me." And again, as a leader, we have to lead from the front. We can't be the one sitting in the back and dictating orders to others and telling them what to do and where to go. I find that oftentimes you lose respect for those around you, your staff, your assistants, your front desk, when you don't try and lead from the front. So I always look to him. Again, his books are phenomenal. If anyone is interested afterwards, I could point you in the right direction, but he's someone I look to as a phenomenal leader. And then another thing when it comes to medical emergencies, other than being a leader, that I always take to heart is when I was in resident on anesthesia, I would do surgery in the OR with a gentleman by the name of Dr. David Zeltzman. He was a phenomenal thoracic surgeon, but he was very intense, and he wanted things done a certain way. He was very particular. And so one day, the photo you see on the left is a patient with tracheal stenosis. So their vocal cords pretty much have narrowed down to the size of that little, almost the width of a straw. And we needed to intubate him for his surgery. And I remember the anesthesiologist said, Rob, you're going to intubate this person today. You're ready to try it. And I remember being so incredibly nervous because it was Dr. Zeltzman. And if I do something wrong, it's going to be a disaster. And so I remember as I was trying to intubate the patient, as I was starting, Dr. Zeltzman hovered over my shoulder and literally whispered in my ear, this big burly man. He said, "Slow down, take your time." And that always stuck with me because in my worry and my stress, I was frenzied. I was frantic. I was worried. I was nervous. I was scared. And I just remember him just bringing this sense of calm, and in talking through emergencies with other people and giving this presentation to others, everyone needs to realize that not only do you have to be the leader, but you also have more time than you truly think. In an emergency situation, things could get crazy, things get hectic, but always try and take a second to take a deep breath and tell yourself, I have time to think this through. I have time to try and figure out what's going on and to treat it. So another pearl to take from Dr. Zeltzman. Now, as far as dealing with emergencies, there is some equipment that I think most dentists should have in their office. It's really not that many things, and we're going to go into the reasons why in a little bit. But the main things here is on the left side of the screen here, we have a portable oxygen tank. Most dentists do have that somewhere in the office. It's important to check it from time to time to make sure it's still operational. Usually attached in a bag to that is the thing to the right, which is an ambu bag that we use to help ventilate a patient in an emergency. I put this picture here, and again, any Stony Brookers might get a laugh out of this picture of Tang. And I think one of the emergency medications we all should have in our office is some sort of sugar or carbohydrate. And at Stony Brook, whenever we were there and maybe a patient was having a tough go or starting to show signs of passing out or fainting, they would call a team alert, and everyone would hover to the patient and just start saying, "Where's the Tang?" and "Get the Tang," and "Mix up the Tang." And it was kind of a running joke at Stony Brook for a long time, but it is something, whether it be Tang or whether it be any type of juice, it's something that is used in emergencies. And so we should have it on hand in our offices. To the right of that is an AED, which we all should have in our office at this point. I'll actually give a shout out to my dad. When he got his AED in his office, he said that the guy who gave it to him said, "Now this is for you, not for a patient." So I thought that was funny because, again, a lot of emergencies we see aren't to patients. It's actually to the doctor in the office or to someone else, an assistant, an office manager, someone like that. So these are 4 things that are important to have. Just to finish some of the equipment here, I put a basic life support certificate on there because I think it's important not just for the doctor in the office to have a BLS certification, but someone else in the office that's there frequently, whether it be an assistant or the manager or someone up front. Again, if you were the one to go down and you're the only one that has taken BLS, then you're kind of in a tough situation. So I think it's important to get at least some of your staff involved, learn CPR. It's very easy, very basic, but I think it really could go a long way. The middle picture here is a pulse oximeter. With COVID, these have become almost famous because a lot of people are worried about their oxygen saturation, but this is another great thing to have in your office. It's battery powered. You can throw it in the drawer. And again, next to that is an automated blood pressure cuff. Again, another thing that's very useful to have in the office. I would hope that all of us have some sort of blood pressure cuff in our offices. But this is pretty much the equipment I feel that all dentists should have in their office when dealing with an emergency. There's not many other things in putting this presentation together that I could think of. So what I figured, instead of just starting to go down a laundry list of emergencies and complications and how to deal with them, I figured that we should go through a day of days. We'll keep on our World War II theme here. A D-Day, so to speak, for a dentist. We'll go through a day for a dentist where some things unfortunately go wrong, and we'll use that as a way of kind of going through some emergencies and some complications. So let's start off. Our 8:30 a.m. patient comes in, starting our new day today, and you have a 68-year-old non-English speaking female who presents for extraction of tooth number 3. This is actually a patient that presented to our office, and all of the cases and the appointments that we go through today are actually patients or events that happened either in our offices or in a colleague's office. So these are all things that really happened. She had a history of diabetes. She did have a history of stroke, and she had dental anxiety. She was non-English speaking, which is going to turn into an issue as we go through. She actually spoke Cantonese, and her daughter was with her to help with translation. So we consent the patient, we get her anesthetized, and we're going to hit our first complication. So something as simple as a complication is a crown fracture. So in the X-ray, you could see that the restorations next to the teeth are pretty tight there, kind of some overhang there. And ideally, you don't want to use a straight elevator so much there because you don't want to dislodge any of the adjacent restorations or even an onlay there. And so you go right to your forceps and you're pushing and you're luxating, and the crown fractures. And the question is, so now what? You have this complication, it's your first patient of the day, and you say, how do I address this? And the old school way of thinking, the way that some of my mentors taught me is, well, if you need to get the roots out, you have to elevate a flap. You need to burr down all the buccal bone to get the roots exposed and then get the roots out. But really, the way you fix this complication is to talk about sectioning a tooth. And I know I alluded to this in my last lecture, but I think it's a very important principle. And a lot of people talk about sectioning as an atraumatic extraction, but I don't really, again, I don't love that term because I think any surgery, any extraction is traumatic. I think the goal is preservation. So I think in this day and age, the goal is to get the tooth out without interfering or having any issue arise with any adjacent structures. So any tooth can be sectioned, even a canine, a lateral incisor. And I think just by sectioning teeth to preserve the buccal plate, preserve the buccal bone is really the way we should be dealing with this complication of a crown fracture. And one of my main mentors, Dr. Michael Lesson, when we were residents, and a few of us on here will remember, even the easiest of teeth in the clinic, he would always say, I don't care, I want you to section the tooth, because he wanted us to get used to having to section each and every tooth as residents, so that when we got out into private practice, we were comfortable with doing extractions this way. Now, many people say, well, you section this molar in the bottom right here, and I see where the roots are, but how do you get those roots out? There's no flap, you didn't touch the buccal gingiva, what do you do? And so this was a picture many had asked for after my last lecture, but there are certain instruments we can use that really do help with extracting teeth. On the right, we'll go from left to right. On the left here, this is a root approximating forceps. It has a very narrow beak with serrations, which really allows you to get into a socket to get a root out. We use that frequently. Very commonly in our practice, we use these two spade type elevators. These are called root approximators. They do a great job of just kind of shimmying in the PDL space of a root to help luxate it to deliver it. The next two forceps, actually, the next one is a universal pediatric forceps, which on anterior maxillary teeth sometimes works wonders. It is smaller and allows to get a better purchase on the tooth. A lot of upper universal forceps tend to rotate on teeth and you can't get kind of the grip that you want. The next forceps next to it, we call it a gold handle, and it's a really great maxillary forceps because the beaks have a diamond coating on them that's very abrasive. So it really allows you to get a really good grip of the tooth or the root to remove it. And the one next to it is kind of a modified cow horn. It's we call it a Bergie in honor of Dr. Berg, one of the founders of our practice. But it's a number 17 lower forceps, and it's not as severely pitched in the beaks as a typical cow horn, but this fits perfectly into a furcation of a lower molar. And actually, with a pumping motion of this forceps, it kind of almost like a hydraulic press brings the tooth up to deliver it. So these are some of the instruments we use when dealing with the complication of a crown fracture. And so this patient, we get the tooth out, thankfully everything goes well, but while we're suturing, the patient becomes lethargic, pale, the patient starts to sweat, and they start to become kind of unresponsive. And as I alluded to in the beginning, the issue with this case and with this patient was that she spoke Cantonese. And at this point, the daughter who was translating actually stepped out of the office to get a cup of coffee while we were doing the procedure. So we had a language barrier that, we couldn't really figure out the exact reason why she was feeling this way. So when dealing with all emergencies, I think it's very important. The first thing is to think of a differential diagnosis. What could be happening to this patient that's leading to this emergency? And then I'm going to go through quickly a few algorithms for what the differentials could be so that we have a better idea of what's going on. And so for this patient, obviously our differential, I'm sure many of you already said, syncope or fainting. She had a history of diabetes. Is it hypoglycemia? Is she having a stroke? She already had a stroke. It could be any of these three. And so just to go into the three, and I put a lot of these predisposing factors and signs and symptoms in the lecture for completeness, but I'm not going to review every one of them. But when it comes to fainting, a predisposing factor, let's face it, it's any dental patient, right? As an oral surgeon, whenever a patient comes to see me, usually the first thing in their mouth, if they're a man, they're like, I don't want to be here. And I could think of 1,000 other places I'd rather be. And most women actually will come in and say, I'd rather give birth than be in the office right now. So it is a anxiety-driven area and place to go in general. So many people are predisposed to syncope. And the thing about the signs and symptoms when it comes to syncope is all of us with time, because this happens relatively frequently, start to learn the signs early. You start to see that patient change their attitude. They start to get maybe a little more quiet. They start to get a little pale. They start to sweat a little bit at their forehead. And when it comes to syncope, it's very important to kind of ascertain that right away, see it kind of coming before the patient explains it or says it, and start treating it. So with syncope, it's all about seeing those signs initially early on. And when it comes time to manage syncope, in all the management of any of these emergencies, I'm going to highlight a few things, and you're going to notice in all of the emergencies we're going to deal with tonight, I highlight the 5 things in red, because when it comes to any emergency, if you could just remember these 5 things to start, to get you off the ground, then start treating the emergency, you're going to be okay. And a lot of people say, what do you mean assess the level of consciousness? You know, ABCs, airway, breathing, circulation, or now they say CAB, you know, that pretty much is something you do as you're working the patient up. Because if the patient is still talking to you, you know, they're starting to get unresponsive, but they're talking, well, they're conscious, they are talking, so they have an airway, they're breathing because they're talking to you. And if they're talking, they have a pulse. So as you're working the patient up and doing this differential in your head, you're also going through these 5 things. Now, if it is syncope, in blue, I have highlighted what is the most common ways that we treat this. So when you start seeing those signs, you put a cool compress on their head and you lean them back. And I know many of us have done this in our office. Administering some oxygen, if you do have it handy, is very important. And usually 99% of the time, the patient recovers. And usually they recover enough that you can continue with your procedure or finish your procedure. If the patient happens to come unconscious or persistently unconscious, at that point in our dental office, it's important to call EMS, in my opinion, no matter what, because something else could be going on. And so that's how we would manage a syncopal episode in our office. Now, if we're concerned for hypoglycemia, which is a low blood sugar, we want to look at some predisposing factors. And in the dental office, the main things that we see is either a patient who comes in who took their medication or insulin, but didn't eat breakfast. That's always a concerning thing. So for our diabetics, it's important to ask those questions. Or sometimes our older patients may have taken too much. They may have gotten confused in the morning and not remembered how much insulin to take or how much medication to take, and that could put them in a state of hypoglycemia. The good thing, though, is that oftentimes when it comes to signs and symptoms, although they can mimic syncope, a lot of people with diabetes for a long time, they know their what's called a prodromal phase. They know their body well enough to know when their sugar's getting low. They'll start to say to you, I'm not feeling right. I think my sugar might be low. And when a patient starts saying things like that, that for them means we need to address it right away. And as many of us know, when we want to treat hypoglycemia, main thing is make the patient comfortable and make them sweet, right? That's what Dr. Cuisine also always used to teach us. It's always better to be sweet. So this is when you bring out that tang, or in our office, we have apple juice, and you administer oral carbohydrate, and usually they improve very quickly. Again, the same things highlighted in red, though. Assess their level of consciousness. It's always good in an emergency to administer oxygen. You really can't go wrong with that. Again, if you have a blood pressure cuff or a pulse ox that you could just throw on their finger or arm, that's always helpful. If they do become unconscious, you do have to obviously call EMS, but most of the time with a little carbohydrate, a little sugar, they get better. And again, the thing you have to remember, if at all in your head you think there's an emergency related to their blood sugar, but you're unsure if it's hypo or hyper, just give them the sugar, because it's always better to be sweet. It's always more treatable if they're hyperglycemic than if they're hypo. So that's how we would manage our hypoglycemic patients. And the reason why I bring up stroke as the third in the differential, not only because she has a history of stroke, is because I'm not sure if many of you have seen, but in our practices in leading edge with the COVID pandemic over the last now almost 3 years, we've really seen an increase in blood clotting issues in patients, especially younger patients. And unfortunately, we've had a lot of stories in our offices of younger patients, either after COVID, after the vaccine, after COVID and the vaccine, they don't know why, who developed blood clotting problems and either had a stroke or had a heart attack. And so I think it's very important to highlight stroke again as a possible etiology of a differential diagnosis. The signs and symptoms, again, I'm not going to go through them, but again, they can mimic very easily many of the things with syncope or hypoglycemia. But the one thing I want to point out on the right of the next slide here is the Cincinnati pre-hospital stroke scale. This pretty much gives you a few parameters that if you see in your office, you need to be concerned for a stroke. And the main thing for us as dentists, because we're working in the mouth, is facial droop. So if the patient starts having one side of their face be droopy, or they're unable to kind of lift their smile, those would be concerning. Are they having a stroke? And The other thing too would be abnormal speech. If all of a sudden they're talking to you normally and then all of a sudden slurring their words, and they typically don't know they're slurring their words. That's one thing, one caveat to this. They might just be talking and have no idea they're slurring. Those are reasons why you might want to be suspicious of a stroke. And again, in managing a stroke, we have the main 5 things there. But with a stroke, if you suspect it, the number one thing is call it in, call EMS and get them to your office as fast as they can. Because when it comes to treating a stroke in a hospital, it's all about time from initial presentation until treatment. That's how the percentages of survivability go up and down. So if you suspect it, even if you have a little doubt, still call it in. It never hurts to get them to the hospital to at least rule it out. And so on our day of days here, again, we started our 8:30 a.m. patient, kind of tricky, a tough extraction with a crown fracture. We remember to section the tooth, not to elevate a flap if we can. We have new instruments, which really helped us with the extraction. We dealt with a small emergency that's pretty common. And in this patient in particularly, it actually was hypoglycemic induced loss of consciousness. As she was beginning to lose consciousness, we were simultaneously leaning her back, putting a cold compress on her head. She wasn't really improving. By then, my staff had brought in our apple juice. We gave her some apple juice, and she bounced back very quickly. So in this case, that's what we saw, and that's what we got. And so this was our first 8:30 a.m. case. And what we're going to do is move on to our next patient of the day. So 10:30, our next patient comes in.
Rob, can you
Yes.
hear me?
Yes.
It's Tracy.
Hi, Tracy.
How are you? So she was conscious enough to take in PO intake?
Yes, she was conscious enough to take the apple juice through a straw. If she was unconscious at that point, then you do not administer an oral carbohydrate. You do not put anything in their mouth. Obviously, you risk them choking. Most general dentists, unfortunately, I don't think have any type of sugar that could be administered intramuscularly. But that would be the next move if they are unconscious. But if they are unconscious and you ruled out a fainting episode, you weren't able to get them any carbohydrates, at that point, you got to get EMS on board in the dental office. Obviously, in our offices, it would be a little different.
Right. All right. Thanks.
No problem. So 10:30, our patient comes in. And the reason why I want to go through times too is because the other really hard thing about dentistry is, we all had those days at 8:30 in the morning where that patient was our first patient, right? And it kind of throws you off your rocker a little bit. It's difficult, it's hard. And you have to then completely change your focus. That patient was fine, they left. Then all of a sudden, your 10:30 patient's in the room, you're ready to go. And it's sometimes hard to get over that first patient. And I think that's one thing that makes dentistry so hard. You see multiple patients a day, and it's very hard at times to leave one, clear your mind, and get to the next. So our next patient, our 10:30, is an 86-year-old male who presents for extraction of tooth number 30. And he says that he has a history of a heart valve replacement. And so right off the bat, you're reviewing his medical history and you say, did you pre-medicate? You have a heart valve replacement? And they say no. And so we're going to review the complication of pre-medication because things have changed. And I did review this in my prior lecture, but many asked for this to be represented tonight. To review what is indicated for pre-medication is the same for heart issues, and they're listed here. As far as what procedures require pre-medication, pretty much anything in a dental office, give or take, requires pre-medication. And I think overall, if there's a doubt in your mind, it's safer to just give the pre-medication. It is very benign to give the pre-medication. If you're doing extraction, it's been shown even in literature to do a pre-medication dose of antibiotics is helpful to reduce infection rates. So even if you're not helping it from their heart standpoint, you're helping from a post-operative infection standpoint. So I think it's important to always give pre-medication, especially if there's one of these heart issues. But the main issue is that both the American Heart Association, the ADA, all of the societies that we all deal with have changed what antibiotic to give after amoxicillin. And what they have done is they've taken out clindamycin. Clindamycin, unfortunately, has a tough therapeutic index of tolerability. A lot of patients have side effects from taking it. And over the years now, they're finding that it really isn't a great antibiotic to prevent or to fight infections from dental issues. So they actually took clindamycin off the list. My issue with the list is they added in a cephalosporin. And as many of you know, many patients who are allergic to penicillin, if it's a true allergy, can show sensitivity to a cephalosporin as well. And so when it comes down to it, they're saying I don't know why, pardon me for a second, something just popped on my screen there. But what they're saying is if they can't get amoxicillin, you give them a cephalosporin, but if there's a reactivity, and now some say it's up to 10%, really in the literature, it's probably closer to only 2%. I don't want to even take that risk in my office. So now if a patient's allergic to amoxicillin, I go to azithromycin or doxycycline. It's still in the parameters. It's still on the graph we see here, but I just don't want to mess around with that potential joint sensitivity to both medications. And so that's one thing and one caveat with the new premedication guidelines. So you give the patient pre-medication, you wait about a half hour, 20 minutes, and you start your extraction. And of course, it's the day of days. You go to luxate and deliver the tooth. And of course, the crown on tooth number 31, not number 30, dislodges. So we all know what an inconvenience this is. You got to get the temporary cement out, you got to clean the tooth up, and now you're kind of running behind in your office. So what you end up doing is you don't put any packing in, you put the cement in that tooth and you go to put it on all the way in the back on tooth number 31. And what happens? The crown disappears. And so now we have a bit of emergency on our hands. We lost a crown. We don't know exactly where to go, but we think of our differential, and our differential is going to include, did we aspirate it? Did it go into the lung, or did we swallow it? Did it go into the GI system? And so to review these two emergencies, so aspiration, which is going to be the same predisposing factors as swallowing, it's pretty much, when it comes down to it, the fact that we use small things in our offices, implant parts, endo files, endo instruments, healing abutments, drivers, and we fail to appropriately protect the throat, whether it be using a floss ligated to the driver or the bite block, whether we use a rubber dam for a root canal, or whether we just use a gauze throat drape when we're taking out a tooth. It always comes down to that. You didn't protect the throat properly. And the issue with aspiration and when something's swallowed is, yes, many times they might start coughing or hacking, and God willing, they'll hack whatever object is up. But we've seen before, and in this case, which is actually a colleague of ours, they were asymptomatic. The tooth disappeared, and the crown disappeared, and the patient was talking normal, didn't cough, didn't do anything. Now, the dentist, the oral surgeon, was a bit concerned. So in managing someone who you suspect for aspiration, pretty much it's the same 5 things in red. Make sure they're stable, support the patient as best as you can, monitor them. Again, this patient was asymptomatic, and refer for radiographs. And in this case, you would refer them for a chest x-ray if you're concerned. And unfortunately for this patient and for this oral surgeon, the crown, this metallic object, was stuck in the right part of the patient's lung. And so that was a bit of an issue, and we're going to go into what ended up happening because it gets better based on this patient. But what happens if it's swallowed? Again, it's the same predisposing factors. And the main thing is you didn't protect the throat well enough, whether it be a piece of floss, again, rubber dam, or a piece of gauze. Again, with swallowing, it's the same signs and symptoms. It could be anything from a hacking cough to nothing, and that's what gets it concerning. Treating a swallowed object, and again, you could see some radiographs here. Again, in this regard, if you are sure and not that worried that they may have aspirated, which again makes me a little worried, and you don't want to refer them for a radiograph, I think it's important that you read your patient. You know, if this is a patient that you've known for 30, 40 years in your practice, you're very confident they swallow this object, then maybe you want to just say, listen, why don't you monitor your bowel movements for a couple of days? If it's a new patient right off the street who swallowed a very large object and you're really unsure, then I think that means you have to get the radiograph. Medical legally, obviously, we all would know you need to send them for at least a chest x-ray. And actually, a little funny anecdotal story, I was on call, actually we were covering one of the Islanders games as their oral surgeons, and I get a call from a patient of a local dentist, and he said, I'm in Aruba. And I said, well, that's fantastic, I'm happy for you. And he said, before I left from Aruba, my dentist cemented in a 4-unit bridge, and I was just at a really nice dinner, and I swallowed the entire 4-unit bridge, and I'm in Aruba. What do I do? And I said, well, obviously, I don't know Aruba. I don't know how easily you could go get an x-ray. A 4-unit bridge is pretty sizable to swallow. I said, I think the best bet in this situation is you just, monitor your bowel movements for the next couple of days, and hopefully you pass it. And fortunately for us, a few days later, we called him each day. And about 2 days later, he had called us in the morning and said, he found it. And so thankfully he passed the object. But it is important to at least try and cover yourself, in my opinion. No one likes it, is inconvenient, but to get that radiograph really makes you sleep better at night. So that's something to think about. So unfortunately for this patient, as I said, it was aspirated into their lung. And so the next step was to send them to the ER. And unfortunately, when the patient got to the ER, the dentist, the oral surgeon was called, and the attending in the ER said, listen, we have your patient here with a crown in their lung, but they're bleeding profusely from the extraction site that you just did. And so now the dentist, now the oral surgeon, is starting to think, what do I do? And so what I wanted to review, because this is a call that we get all the time on call, whether it be a patient at home, a patient in the hospital, how do I deal with bleeding? And so my little algorithm with bleeding is typically bleeding is due to something called a liver clot. A liver clot, and you can see in the picture here, is a very gelatinous, I tell patients it looks like dark red jello clot that forms improperly. And so because the clot forms improperly, you are unable to stop the bleeding totally. It will continue to ooze until you correct it. And so I usually recommend to patients, number one, take some gauze or a paper towel or a napkin and clean the area thoroughly until you could see the gums again. So clean all that jello type material out first. And then at that point, don't use dry gauze. I usually recommend to put some gauze in ice cold water and bring them out like a sponge so they're damp and cold. And then I say to bite down on the gauze for about 30 minutes. 30 minutes works very well because if they keep taking the gauze in and out, it'll never clot. You keep pulling out the clot as it goes. And I've learned over the years that after about 3 times of doing that, it stops the bleeding most of the time. If it doesn't, you can have them use a cold, damp tea bag in the same manner. There are acids in the tea bag that do help blood clot. And I'd say majority of patients do clot after that. And when they don't, if you get a call back after a few hours and they're still bleeding, at that point, you really want to reassess their medical history. Is there something we missed? Is there a blood thinner we weren't told about? What could be going wrong? Because most healthy individuals will stop bleeding, or their bleeding time, which is a number that can be calculated, is usually about 9 to 10 minutes. So most of the time, this algorithm works. Just to review, I had this up last time and many asked for a copy of it. This is a nice diagram of all the blood thinners we run into on pretty much a daily basis now. Coumadin, Xarelto, Eliquis, Plavix, and its recommendations for how to deal with them. One thing I do say about Xarelto and Eliquis in this diagram, they do say that if you're only taking out one tooth, you really don't need to stop it. Unfortunately, we do see a lot of bleeding because we do extractions all day, every day. And I would say if the doctor is willing to allow the patient to come off even for an extraction, I do think it is still beneficial. If not, for one tooth, you should be okay. But this is a great little chart to have. So to wrap up our 10:30 a.m. patient here, we ran into a few complications along the way, whether it be premedication and bleeding. We had an aspirated crown, and this patient actually had to go to the operating room for a bronchoscopy where the crown was removed from their lung. They survived, everything went fine. And unfortunately, because there was no throat pack, just so everyone could have completeness, this was settled out of court between the doctor and the patient. So something hard for me to really think about. So we get through the day and we had a few cancellations. We zoned everything out from the morning and we were at our lunch break. We have a nice lunch planned. And at 1:30, someone walks in the door. This is the next case that we're going to talk about is actually a case that happened to Dr. Rosenberg, Tracy Rosenberg, and myself in the office on a Saturday. A 32-year-old female woman walks into the office in excruciating pain. And she says she's 30 weeks pregnant. She's in terrible distress. She's keeled over at the front desk. The front desk calls us right away and says, listen, something's not right. This woman is in a world of pain. What do we do? And so we said, well, let's get her up, get her into her room, get her into an operatory. We were finishing up with our prior patients. And we told the assistants, get in the room, try and calm her down a bit and get a blood pressure. And they do. And they get a blood pressure on this pregnant woman and it's 190 or over 115. And so they run out of the room and now they run to Tracy and they run to me and they say, she's not looking good. There's something wrong. And so Tracy actually was the first in the room. And as we get in the room, she loses consciousness and starts seizing. So I wanted to just review a little bit of the differential diagnosis. Obviously, we know she's seizing, and we're going to talk about why she's seizing, but I also want to just review quickly these emergencies. So a seizure has a lot of predisposing factors, but a typical seizure, not in a pregnant person, just general seizures. The thing that is somewhat good about patients with seizures is typically they have what's called epilepsy, which is a history of chronic seizures. And when they have a history of seizures, it's good in regards to treating them because they usually know what their triggers are. So you always could ask what their trigger is to having a seizure. And typically they're all very well controlled on medication. So they may not have had seizures for quite some time. When we deal with those patients, we typically try and make them very comfortable, make them feel at ease, do smaller, shorter appointments. But that's the good thing about a typical seizure, is that the patient typically presents with a pattern or consistency. And those are important questions to ask, and they're predisposing factors. As far as signs and symptoms, I'm sure we've all seen or watched on TV or seen on a TV show a patient seizing. But in the dental chair, how do we manage it? Again, we just go through the things in red. You know, what are the things that are life-threatening, and how could we keep the patient safe? And for a seizure, there's not much in a dental office that we really could do except protect the patient, take off any drape. You don't want anything around their neck, remove anything sharp, any objects around them, remove the tray and any instruments. And the one controversial thing about seizures is, you know, for ages, they'd say, well, shove something in their mouth so that they don't bite their tongue. And the answer to that is good. But you also don't want to shove something in their mouth that pushes their tongue posteriorly and occludes their airway. I usually recommend, when I discuss medical emergencies, that dentists are pretty good at knowing the mouth. So a dentist, if they feel comfortable trying to get some sort of apparatus in their mouth to prevent them from clenching down, I think is something they could do. Dr. Cuisine, in his lecture, always used to talk about, at a gas station, a man saw another fellow fall and have a seizure, and he took his wallet out of his pocket and stuck it in the front part of his mouth, because his wallet was very thick and almost like a wedge, and it didn't get wedged too far back, but it kept his mouth open to get him through his seizure. So just food for thought, something to think about. I think most dentists would feel comfortable trying to do that. And if you don't, it's not the end of the world. But again, when we manage in the dental office a seizure, again, oxygen, monitor their vital signs if you can, and call EMS, get them to the office. All right, let's see. So I want to review eclampsia just for a second, but I really just want to talk at a greater appreciation for pregnancy. And there's a few things I wanted to review quickly. But when it comes to eclampsia, which is a woman who's pregnant has some predisposing issues like hypertension or protein in their urine, who then develops a seizure. So they go from pre-eclampsia, which many women have during pregnancy, into eclampsia. I'm going to talk about what is the reason that eclampsia is so serious, but the signs and symptoms, actually, I gained such a great appreciation after this medical emergency, because my wife and I just had our third baby girl. And our OB, his name's Dr. Jeff Miller, he's a phenomenal OB. Every time my wife went to his office, he would take her blood pressure manually himself. He would look at her face really descriptively, like take his time to really look at her face. He always would look at her hands and her feet. And he always would ask questions like, do you have any headaches or vision issues? And it wasn't until I saw this case and kind of put the pieces of the puzzle together that OBs are really looking to see if you are showing signs of eclampsia, because that is such a medical emergency and danger that they need to try and keep that from happening from a patient who has preeclampsia. So in managing a patient who's seizing from eclampsia, like the patient we're seeing again in the dental office, it's very similar to the seizure management. But the one thing I wanted to bring up tonight is, in managing any pregnant patient in general, in this day and age, I know many people have gone through this, and I feel for you. My wife and I had a lot of issues with getting pregnant and starting our family. Pregnancies in this day and age, for whatever reason, are much more tricky, much more difficult. People are having a much more difficult time getting pregnant, sustaining a pregnancy, having the baby. There's just so many more issues. A lot of people are going to IVF and other ways to try and have children. And I really don't know the reasons why it's happening, but what I do know is it's not always very simple like it was maybe years ago, where patients would just, they called them fertile myrtles. They always were coming in pregnant. It's very difficult. So when you manage a patient who is pregnant, I always recommend, because of the issues that could arise, get an OB consultation, see what they recommend. Always check their blood pressure, because you could be the one that sees that their blood pressure is high. Only deal with emergencies, and if you can, in the second trimester. And I think when we deal with pregnant patients, that's very important. And hypertension, I don't want to hit on too long tonight. I know we got a little lost track of time in the beginning of the lecture with the AV issues, but it's not so much the hypertension when we have a patient who has a high blood pressure that we're concerned about. It's really a patient who's showing symptoms of high blood pressure that we worry about. So if you have an older woman who comes to your office and she's always 160 or 170 over 90, and she's happy as a clam and looks great, it's probably okay to treat her, because that's where she runs every day of her life. But if she comes in and she's usually 140 over 80, and now she's 160 over 90, and she's saying, I've had a headache all day, those are patients with symptomatic hypertension that we have to be really worried about and we have to be concerned about. Again, in managing them, mainly it's keeping them comfortable, some say to lower the lights in the room, put on calming music, administer oxygen is very important. And if they're symptomatic, I don't believe so much in like urgency or emergency. There's all these different classifications. If they have symptomatic hypertension, you got to get them to a hospital. You got to call EMS. So it's just one little thing I wanted to bring up about a symptomatic hypertensive patient. And so to finish our 130 patient, again, she was having a seizure. She was in eclampsia. Tracy put in an oral pharyngeal airway. I established an IV to help when EMS arrived. We monitored her vital signs. We protected her. We kept her as comfortable as we could. And she seized for the entire time until EMS came. She seized for the entire time that she was transferred to the ambulance. And she seized till she got to the hospital. Once she got to the hospital, the way you treat eclampsia is to have the baby. So she had an emergency C-section. And thank God that both the mom and the baby survived and are healthy. So it was quite a Saturday in our office. And for this day of days, our 130 patient, quite the day. We are getting a little short on time tonight, so I'm just going to go through our last patient of the day, and we'll go a little quicker through this for everybody. But so our last patient of the day, if it could get any worse, our 4 o'clock patient, again, we kind of zoned out everyone before us. We're focused on our 4 o'clock patient, and we see routine extraction of number 20, a conical root. Hopefully an ash forceps will rotate this right out, but the endodontist said they saw a fracture in the pulpal floor. And so you anesthetize the patient, and what always happens at 4 o'clock, patient won't get numb. That's always a complication, always an issue, mainly with mandibular teeth. I did discuss this in my last lecture, and many asked again for me to repeat it. I'm going to go through it quickly, how to anesthetize, or how I anesthetize for a extraction of a tooth. The maxilla, I'll be honest, is usually very straightforward. In the maxilla, I use purely Septicaine. I started, if you could see the cursor on the screen, by giving 3/4 of a carpule in the buccal fold. I do use topical, whether it works physically, mentally, spiritually, it's something for the patient, and I do use topical. I do give that 3/4 carpule in the fold. I use the other 1/4 of the carpule then palatally as a quick 1, 2, 3 injection, and then I stop. I give the patient some time to let the anesthesia set in, and then I go in with a second carpule of Septicaine without even touching the tooth. I don't even try. I always go right to a second carpule, and I give the rest as little infiltrations in both papilla until they blanch, and then more on the palate. Now that it's already been anesthetized, it's more tolerable. And I'd say 99% of the time that works well. In a mandibular case, which is usually where we have trouble, I always start down here. I always give 2 blocks for an extraction right off the bat. I don't waste my time trying to do one. I give 2 blocks, and for the block, I do give lidocaine. I don't give Septicaine. Once I give the block and maybe a little long buccal block, I then go from there, and once the patient is numb, to using Septicaine. And I use Septicaine the same way in the maxilla. I give little infiltrations in the papilla to blanch the tissue, and I always give a little Septicaine lingually to get the lingual tissues as well. And that typically works very well for anesthesia. So you get anesthesia and you finally get the tooth out, and I'm just going to glance over it quickly again because we do get calls about this still frequently. You get the procedure done and you run into another complication, this time premedication, but they had a knee replacement. And I know many now know that the ADA and many orthopedic societies now recommend that we don't premedicate for any type of joint replacement. The issue that we find a lot in our office is a lot of these people have been prophylaxing for 20, 30 years. You know, I always do it, doc. It's always a thing. And I think it's hard because you don't want to get in a fight with a patient. And so what I say is we typically don't have to do it. But if that is that one tough patient who says, I've been doing it and I want to keep doing it, one preoperative dose of amoxicillin I don't think is going to do anything harmful. And again, it kind of prevents losing trust with the patient. But overall, we don't need to premedicate anymore. So going into finishing up some of our emergencies. So you finally get through your complications, you're breathing easy. And on the way out, the patient comes to you and says, my chest is really starting to hurt. I'm feeling a lot of pain. I'm feeling a lot of tightness. Now, when it comes to a differential for something like this, I always recommend think about what anatomy is in the area and what could theoretically kill the patient the fastest. And when it comes to the chest, we immediately say the heart. So with the differential, when any type of chest pain, we want to go right into what could be going on. Could it be angina? Could it be a myocardial infarction? Or something as simply as indigestion or GERD or reflux or an ulcer? And so I'm going to just focus on the top 2 here, pardon me, for time. But When it comes to a patient with just generalized chest pain, I liken a person with angina with chest pain to our seizure patients. They typically are stable and have a pattern and a consistency to their symptoms. They typically know what exacerbates their chest pain. They typically know how to treat it. They typically know when it comes on, and they typically know kind of like a prodromal phase. So when we deal with it, it's usually in the history, if they do say they get chest pain, that we could get a lot of our answers, just like we can with a seizure patient. And again, when we're treating them, some dentists do keep nitroglycerin in their offices. It's not a bad thing to keep. The only issue with nitroglycerin, if you do keep it in your office, it expires very quickly. It expires for some reason very quickly. So it is a bit annoying to keep it in your office if you, in fact, will never use it. So again, the red bullet points, chest pain, what are we going to do? Especially if that chest pain is new. If the patient said, listen, I've never felt this way before. You want to make the patient as relaxed and as comfortable as they can. Can they have this chest pain because you didn't have appropriate local anesthesia? Like in this patient, you were trying to take out a tooth that was a sensitive tooth, and they couldn't get anesthetized. But mainly anything new chest pain wise in the dental office means call EMS. Assess their level of consciousness. Oh, they're speaking to you still? Fine. That means their airway is patent, they're breathing, and they have a pulse. Get them on some oxygen, put on your blood pressure cuff and your pulse ox, and get them to the hospital. Now, a myocardial infarction or a heart attack is, again, I alluded to this with stroke, with COVID, and all these patients now developing, and what we're hearing is all these blood clotting issues. We're seeing so many more patients with stories of friends and family who were young and either had a stroke or had a heart attack. And so we are seeing more and more every day patients now who are young and healthy having heart attacks, having strokes, now on blood thinners. And again, with the heart attack, the main sign you're going to see is they really are going to complain about a really tight, crushing chest pain, something typically that they haven't felt before unless they've had a heart attack in the past. If you do see this, the acronym or mnemonic we like to use now is ONAM. I have it listed here, in addition to all the things in red. But that stands for oxygen, nitroglycerin, aspirin, and morphine. Now, in most dental offices, the only thing you're going to have is oxygen and maybe some non-enteric aspirin laying around. If you do, it's okay to give them two. You give them one to chew and one to swallow. If you have nitro in your office, that would be good to give. Most don't have IV morphine. And so that's why it's important to recognize these things early, assess their level of consciousness, and then get EMS on board right away. If you do have these things in your office, then that's great to give them. And so this patient who came in, it was actually a friend of mine's patient, couldn't get numb, stressed out from the procedure, got worked up about his joint replacement, and ended up having a heart attack. And so he was fortunately given oxygen and aspirin in the office. His vital signs remained relatively stable. And when he got to the hospital, he was brought for a catheterization procedure where he had a stent placed. And so just to finish our day of days, to wrap this up, to end the story, let's say the 4 o'clock patient on the way out said, well, I'm going to the hospital, doc, so why don't you take my tickets to the game? Because you had such a crazy day, why don't you go enjoy a night out? So you go to the football game, sitting sidelines, and I'm sure many of you have seen this, but this happens. This happened about 2 weeks ago in an NFL game. I'm sure many here have seen this. And the player, Mr. Hamlin, gets up from tackling his opponent, and when he stands up, he immediately goes unconscious and collapses. So the reason why I bring this up as the last point is not to make light of the situation. This was a tragic incident. It was very scary to watch. It was on live TV. This type of thing, and we're going to get into it, which is a loss of consciousness, a collapse, no pulse, no breathing, is something that we're not necessarily going to see in our office. That's why I put it part of the story as out of the office. This is something you're going to see on the ball field. This is something you're going to see at your kids' lacrosse games. This is what you're going to see when you're out in a restaurant. And it's very important because we're all trained in this to know if you see a patient go down and you can't feel a pulse anywhere and they're not breathing, you have to be ready to do CPR. And I know I stressed this in my last lecture. This is a picture of my uncle. And again, this is at my cousin, his daughter's wedding. He woke up the day after the wedding in cardiac arrest. He collapsed. His wife, my aunt, was a cardiothoracic NP, thank God. Immediately recognized it, started CPR on her husband the day after their daughter's wedding, called on her cell phone on speakerphone 911. They came in on the way to the hospital, shocked him, and he survived. And it was all because she didn't memorize any of the particulars about BLS. All she remembered was compress, 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 and get an AED as fast as we can. And the same with that football player, Mr. Hamlin. In some reports, they were doing CPR for, I think they say in some reports, up to 9 minutes before they got him in the ambulance and were able to shock him, and he still survived. So just one last point about our last emergency, unresponsiveness. If you see it, and you're not going to see it in your office, these are things you're going to typically see out and about. You're trained in it. It's important to have your staff trained in it. But it can truly save a life just simply by doing your compressions and getting someone to find an AED. So fortunately for this football player to end your day, you had to end it by doing CPR, but fortunately he survived, and our day of days are finally over. And I hope that was informative. I'm sorry I did have to rush a little more towards the end, but we lost a little bit of time in the beginning. But if anyone does have any questions, I would be happy to answer them.
We did have one question come through to the chat here. For penicillin allergic patients, what about injecting clindamycin IM, and this negates gastrointestinal issues?
So yes, that is one of the ways, but I still think that the protocol for it is to no longer use clindamycin at all. And so I would say that I wouldn't even reach for it IM. I think giving anything IM has risks associated with it. I know we all get vaccines and stuff, but a bolus of Clinda IM, you could develop a hematoma, you could get infected. It's kind of difficult. So I wouldn't recommend going to clindamycin.
Thank you. And one more I have here. Do you pre-medicate for a total heart transplant 2 years prior?
So yes, a heart transplant is 100% indication for needing pre-medication. The other thing to worry about with heart transplant patients is they're also typically on significant immunosuppressive drugs. So if you're going to do treatment on them, or if you're going to do an extraction on them, it's important to speak with their doctors first, especially their transplant team, because they sometimes want to get lab work. Because of the immunosuppressants, their platelet count might be depleted before you even do the extraction. So not only is pre-medication indicated for cardiac transplant, but you also want to verify with their transplant team before doing anything.
Thank you. We just have a few more here in the chat box. Can we force the instaglucose in possibly hypoglycemic patients?
So the instaglucose is something nice because it has a long shelf life usually, but if they are unconscious, then nothing should go in their mouth, unfortunately. Hypoglycemia, again, is something that we have to prevent. So if your patient is diabetic and any sign comes up that they might be a little altered, they're a little lethargic, they're confused, they're acting differently, in my mind, just give them some sugar before you even get to the point of them being unconscious. But if they're unconscious, then you shouldn't put anything in their mouth. That would be too worrisome.
Great, thank you. We're getting lots of thank yous, lots of great jobs. One more question here for now. What drug do you prefer for pre-medication for someone who is allergic to penicillin?
So again, I get worried. I'm not going to go back to the slide. I get worried about the penicillin because they say the next thing is a cephalosporin. There is some literature showing that there is cross-reactivity between the two as an allergic reaction. So I actually prefer to go to the azithromycin, which is the next thing on the list, or doxycycline. Either of those are written by the American Heart Association as their parameter. So I usually go to that. I usually don't mess around with the cephalosporin because of, again, that small probability or small chance that they have a sensitivity to that as well.
Thank you. One more here. Have you seen cloudy vision post-COVID at all?
So that's very interesting. We have seen very frequently the post-COVID or long COVID fog. Yes. Interestingly enough, I had it for quite some time, a little bit of time over the summer, and I went to a neurologist, and she had said that that is a true thing. This vision issue, fogginess, difficulty concentrating. I told her, my wife kept saying that I'm sounding stupid at home, like I'm not making sense at times. And she said can be a sign of post-COVID or long COVID. And so this fogginess definitely is a thing. They're still trying to figure out how to fix it and how to correct it. But yes, we have heard of that for sure.
Great, thank you. I think that's it for now. Lots of thank yous. If anyone has any more questions, please feel free to go ahead and throw it in the chat. You can also unmute yourself now. Okay, thank you, thank yous. Well, we just want to thank you guys all for coming. We love coming here and being able to put on these webinars for you. So thank you again for joining us for the next webinar of our Leading Edge webinar series. I just wanted to go ahead and here and point out what a great organization we're part of. Dr. Bacigalupo is representing our Leading Edge Oral Surgery Levittown office. We do have 10 offices now located throughout Long Island and New York City. We have Queens and Manhattan. We have 19 highly trained and very experienced oral surgeons. And we are very excited to be welcoming a new office and a few new surgeons in Suffolk this month. So I'm very excited to share that with you all.
Awesome. Thanks, everyone. Have a good night.
Have a good night.
I'll talk to you all soon.